is showtime.
The broadcast is now starting. All attendees are in listen-only mode.
Many times I tried to tell you, many times I cried alone. Always I'm surprised how well you cut my feelings to the bone. Don't wanna leave you really, I've wasted too much time to give you up that easy, to the doubts that complicate your mind. We belong to the light, we belong to the dark. We belong to the sound of the world, we both falling under. Whatever we deny or embrace, the words are for better. We belong together. Maybe it's a sign of weakness when I don't know what to say. Maybe I just wouldn't know what to do with my friends anyway. Maybe because my habit to keep the stars. Now there's no looking forward. Now there's no turning back when you say we belong to the light, we belong to the dark. We belong to the sound of the world, we both falling under. Whatever we deny or embrace, the words are for better. We belong together. Close your eyes and try to think now. Close your eyes and try to dream. Lay your mind and do your best to try and watch the past. We can't begin to know how much we really care. I hear your voice inside me. I see your face everywhere. Say we belong to the light, we belong to the dark. We belong to the sound of the world, we're both falling under. Whatever we deny or embrace, the words are for better. We belong together. We belong to the light, we belong to the dark. We belong to the sound of the world, we're both falling under. Whatever we deny or embrace, the words are for better. We belong
Good morning, everybody. That was Pat Benatar singing her biggest hit, We Belong, and this is Dr. John Minarsik, feeling very much like I do belong here at least. Today is Thursday. It's February 16th. It's 9:02 a.m. in Chicago, and this is our 45th two-hour session on global medical school pathology. Good morning again. We will be discussing today the second part of the big chapter on WBC, or white blood cell disorders. And I don't know, I don't have anything to rant about today. When I gave this course the first year, 2 years ago, I was ranting about everything. I was just so glad to be out of the routine, horrible private practice of medicine and to be able to do this. was still in the cooling off phase, and I had to warn the students, sometimes tell horror stories about what they might get into, but there's been very minimal of that this year. I guess it's a good time to do our little audio-visual test right now, and I'll be asking you all again by looking into the little box here, the question box. Can you hear me okay this morning? Okay, I'm seeing a bunch of yeses, and then the second question is, what do you see now on your screen? Okay, I guess it's sort of a sunrise. I guess it could be a sunset. I don't know, but it's very colorful anyway. And I don't know if this is a natural thing or whether it was Photoshop, but it's spectacular. Okay, got a little tip for you. Even though I don't have a rant, I have a tip for you because I discovered something in the middle of the night when I got up and was reviewing my PowerPoints. For those of you that have iPads or iPods or iPhones, it's probably even on the Androids, I would guess, but I'm not sure. There's a program that is a PDF reader. It is called Good Reader, G-O-O-D Reader. And you could put it on your iPhone or your iPad or your iPod, and you can actually then take your downloaded PowerPoints and convert them into the PDF format on your computer. And then when you transfer them over to your little iPad device, you can see them. But recently it's been updated as of about 1 day ago. I just got the new upgrade. It wasn't present before. Not only can you watch your PowerPoints while you're in class or while you're listening to me, but you could take your little finger and draw notes on them too. And that's something I've always wanted. It's so easy to do now. So remember, for those of you that have tablets, and somebody already said it's on the Android, for those of you who have tablets, remember Goodreader is really a great place to put your PowerPoints after they've been converted to PDFs. No rants. I guess I'm ready to go into some stuff today. I just wanted to take 1 minute to tell you how much I have massively enjoyed doing this. It's been the dream of my lifetime, and you know, I have over 20,000 messages in the last 3 years, emails and comments, in which the phrase "thank you" is in them, and that's the kind of stuff that keeps me going. Yeah, I stopped counting after about 20,000. I can't even keep track of them anymore, but you know, and I really, really, really appreciate that. And I see you saying thank you a lot at the end of the class in the chat box. But let me tell you, you're all wrong. It's really me that should be thanking you, because this has really, really been the most fun of my life. And we're going to start out by having some more fun now with the continuation of Chapter 14. And if you remember, we had made a good start into Chapter 14, WBC disorders, and we were about on PowerPoint number 17. We covered all the basics, all the basic anatomy and physiology, and some of the disease classifications, and some of the basic reasons for elevation or lowering of the white blood cells. And this is exactly where we left off over here. We covered just about all the cells except for eosinophils and basophils, you know, the rarest of peripheral blood cells. Eosinophils are only a couple percent, 2-3 on the average, and basophils are hardly ever over 1. They're usually less than 1%. Nevertheless, let's talk about them. And it's going to be easy to talk about them because there are clinical conditions that cause eosinophilia and basophilia, but there aren't any common clinical conditions that cause eosinopenia or basopenia other than aplastic anemias, which cause penia of everything, or panpenia. So let's talk about the reasons for increases in eosinophils, or counts greater than a couple percent of the normal 5 to 10,000 WBC count. There's only 2 things on the list. There's allergies and there's parasites. And especially in hospitalized patients that are on drugs, drug allergies, okay? Not just allergies to things in the environment. So I want you to remember, when you see an increase in eosinophils on your blood counts, or if you're in pathology lab and you see an increase of eosinophils on the slide, or if you're looking at a bone marrow and you see an increase in eosinophils in the bone marrow, it's almost always allergies or parasites. Now, to tell you the truth, I'm sure that there are some geniuses out there that are a lot smarter than me that could probably add a couple more things on the list. But that would be clouding the issue. You know, there's even a rare type of leukemia in which eosinophils increase, one which you'll never see in your life, by the way. And that would be clouding the issue, because it's always simple to think in terms of the common, simple things. Allergies and parasites are the reasons over 95% of the time for eosinophilia. And it's also makes things easy if you remember that I have never heard the word eosinopenia in my life. I just made it up at the bottom of the PowerPoint. So the granules that you see here in the eosinophils, in terms of recognition in the lab, no matter how the stain is done, no matter how lousy the stain is, or how dark, or how light, or whether the tech did it properly, or whether the machine did it properly, the eosinophilic granules are always redder and bigger than the neutrophilic granules. Here's a neutrophil in the northwest. Here's an eosinophil down here in the middle. I'll make it bigger for you. Also, remember, the nucleus of an eosinophil is always bilobed. It's always two lobes. It looks like a Pelger-Hewitt cell. It's only two lobes. It may be connected by a very, very thin, stringy isthmus, but it's always two lobes. Whereas in a neutrophil, it's usually more than two, and with the average of around 3.5, let's say. So that's it for eosinophils. Why are they bigger and why are they redder? Well, to some degree, they have a lot of the similar things that we saw in the granules of neutrophils. But if you wanted to be a little more pure and look at the more specific things, even if you think that these acronyms here are pretty, dumb, major basic protein, MBP, is always listed on the list. Eosinophil cationic protein, eosinophil peroxidase. Remember, we said that there was peroxidase in the neutrophils too, and eosinophil-derived neurotoxin. And rather than go into a nice little research discussion of what all these things do, I think you could just lump them and say that they are generally doing the same things that the granules to the neutrophils do, and they induce a lot of tissue damage, dysfunction, and help out a lot in causing havoc and destroying things in the areas that need to be taken care of with the inflammatory process. So there's your 4 big things in eosinophils. Basophil granules are much, much easier to remember. And even though there is a list here, which I got from Wiki, of a bunch of things like histamine, proteoglycans, chondroitin, proteolytic enzymes, elastase, lysophosphatase, leukotrienes, several cytokines. The best way to remember a basophil is that it has the same basic granules as mast cells. So if you remember that in mast cells, the big granules are histamine and heparin, the 2 big H's, and that's exactly what's in a basophil as well. So I highlighted the 2 H words. Very often, the hematologists might call mast cells tissue basophils, just like we call macrophages tissue monocytes. That's not really true. They're technically from a different origin, but if you want to think those big black granules are the same as what you see in mast cells, that's fine. Another thing to remember is that they are so black, there's absolutely no confusion about them being eosinophilic or granulocyte, no matter how the stain was done. They are so black and so thick and so dense, they almost always hide the actual shape and configuration of the nucleus that's in the middle of the cell. And for that reason, unless you are looking at cells carefully, you're very likely to just write this off as maybe a lymphocyte that looks a little bit more big than usual, or funny, or perhaps crushed, or whatever, because it looks like all of these black granules are so dense that it's the nucleus itself. So be careful. Whenever you see a lymphocyte that looks much, much, much more granular than usual, it's probably a basophil. Basophilia differential diagnosis is practically zero. Okay? It's rare. Basophilia, pure basophilia, is rare, rare, rare. They are often associated with the myeloproliferative diseases, but remember, in the myeloproliferative diseases, almost all the cell lines are increased, not just the basophils. Sometimes the basophils in some of the myeloproliferative diseases, which we'll be discussing soon, like chronic leukemia and P. vera, sometimes they are a little bit increased more than the rest of them are. But clinically, if you're in the wards and your attending physician says, give me the differential diagnosis of basophilia, the correct answer is nothing. And you want to know an even bigger nothing? There is absolutely no such thing that I could remember in my entire life as being basopenia, or selective decreases in basophils, which are already very, very rare. Now, of course, if you have a condition which is causing marrow suppression in general, like aplastic anemias, sure, the basophils will be decreased, but so will everything else, the rest of the white cells, the platelets, and the red cells. Okay, we're done with the basophils and eosinophils. Let's move on to the monocytes. You remember the monocytes are the macrophages before they go into the tissue. So a macrophage is truly a tissue monocyte. And if you remember, when we talked about granulomatous diseases several times, we said the chief cell composing granulomas are macrophages, which are tissue monocytes. So if you wanted to make a quick association and say that the differential diagnosis of monocytosis are granulomatous diseases, that would be a very, very good thing. TB, of course, at the very top of the list. Probably of all cases in your life of extreme monocytosis, truly monocytes, probably there'll be tuberculosis most of the time. The inflammatory bowel diseases, which are even more common, ulcerative colitis, and particularly Crohn's colitis, also called granulomatous colitis. They're also associated with monocytosis. But remember, here's a few things which don't necessarily cause granulomas in tissue, but I think you're just going to have to remember that patients that have a disease we talked about last session, SBE, subacute bacterial endocarditis, the rickettsial diseases, which you may never see, the malaria, which you may see every single day if you're not if you're in a malaria endemic area, and lupus, systemic lupus erythematosus. These are the common things associated with monocytosis. Okay, let's move into the big guy, the second most common type of white blood cell, the lymphocytes. Okay, what is the common clinical thing that you would think of with a patient with lymphocytosis? Well, once again, tuberculosis. If you remember, we may have mentioned this in the infectious disease chapter or pediatrics, the disease pertussis, a bacterial disease caused by a bacteria, is usually associated with an extremely high selective lymphocytosis. So is TB. So TB is not only showing an increase in peripheral monocytes, but also lymphocytes. Now, let's get into the general principle, however, and there's going to be a lot of exceptions to this, so I'm not too sure if you should really remember this as Bible, but do you remember how we said that one of the greatest, most common, overwhelmingly causes of neutrophilia were bacterial infections? Well, if you want to make a little bit of an analogy, the common human viral diseases, like hepatitis A, like CMV, like EBV, these are all very, very common viruses. Viral infections in general are associated with the lymphocytosis, just like bacterial infections in general are associated with increases in neutrophils. Now, it's a little bit of a shaky generalization, and there's a lot of exceptions, but I think it's worth remembering. So there's your basic differential diagnosis of clinical lymphocytosis. Now, I want to tell you something else. Probably a significant lymphocytosis is most common, you'll see it the most commonly, in patients that don't have these infections, but in patients that have a very, very common proliferation, a sort of semi-neoplastic or slightly neoplastic proliferation of mature lymphocytes called chronic lymphocytic leukemia. So patients come in with lymphocyte counts, 2, 3, 4, 5 times normal, what they should be. Most likely, statistically, it's not going to be a viral or a bacterial or a mycobacterial infection. It's probably going to be chronic lymphocytic leukemia. But we'll get into that later. And this is a good time to start out with the concept of myeloproliferative disorders. It's a concept which is a long word. It confuses a lot of people, even pathologists. But, I was really able to, I think, summarize for you the correct definition and the correct differentiation between so-called myeloproliferative disorders, or proliferations of the bone marrow. That's what myeloproliferative means. And the so-called pre-leukemic bone marrows, which are called myelodysplastic. Now, all myelodysplastic bone marrows, which we'll talk about later, can go into a leukemia. Some of the myeloproliferative disorders can go into leukemias as well. But generally, even though the most common myeloproliferative disorder has the word leukemia in it, or chronic myelogenous leukemia, also called chronic granulocytic leukemia, and one of which we discussed in the talk on red blood cells called polycythemia vera, or proliferation of platelets, or fibrosis of the bone marrow. These are your 4 basic myeloproliferative disorders. Now, to make things even a little bit more fuzzy and complicated, even though we like to classify the myeloproliferative disorders, or proliferations of the bone marrow, based on the predominant type of cell that they're proliferating. For example, in chronic myelogenous leukemia, the myeloid cells or granulocytes are increased. In P. vera, the red blood cells are increased. In essential thrombocythemia, which is also called essential thrombocytosis, by the way, it's the platelets that are the primary proliferative cell in the peripheral blood. And then another one called myelofibrosis, in which none of these particular elements are selectively increased, but it's associated with a generalized fibrosis of the marrow. Okay, so what is a myeloproliferative disorder? It's a proliferation of the marrow. And in most of them, even though they're called by the selective cells that proliferate, when you look at the marrow, it's usually almost all the marrow cell lines are affected. For example, in chronic myelogenous leukemia, the platelets and the red cells are also increased. In P. vera, which is red, the platelets and the white cells are also increased. So there's a lot of overlap between the two. Now you want to ask, because a couple of these myeloproliferative disorders, like CML especially, and myelofibrosis, are linked to the development of leukemias, or acute leukemias. I mean, we're already calling CML a chronic leukemia, aren't we? But because they are linked to leukemias, we're asking ourselves, are these malignant? Are these premalignant? Are these neoplastic? Well, that's even a harder question to answer. But I will tell you that normally, if you remember from your normal physiology of the bone marrow, whenever a bone marrow produces an increased number of cells, there is a feedback mechanism to then shut off that production when the cells are no longer needed. But in myeloproliferative disorders, you have proliferation of marrow cells. They have lost their ability to feed back. So proliferating cells do not suppress residual marrow. And another thing is, whenever you need extra white cells, extra platelets, extra red cells, there's usually a reason you need them. With myeloproliferative disorders, these increases just seem to appear spontaneously without a known need. Now here's another concept. Not only does your marrow proliferate in terms of increased number of cells, but it's also an increased cellularity. So remember, we said several times that the normal cellularity of hematopoietic bone marrow is about 50%. In other words, 50% hematopoietic cells, 50% fat. With a lot of these myeloproliferative disorders, most of them, it's much greater than 50%. In chronic myelogenous leukemia, it's usually around 100%. Okay? And not only does your bone marrow expand in terms of numbers of cells, but it also expands from your axial to your appendicular skeleton as well. So if you remember, normal adult bone marrow is only the axial skeleton. But in some of these proliferations, it expands into the long bones, into the humeri, well into the femurs. Now, you want to know a third way that it expands? A third way that it expands is to not only have increased marrow cells in the bone marrow, but it's also expands in having marrow cells outside the bone marrow. Like spleen is always the most commonly mentioned place first, but also liver, also lymph nodes. And that's called extramedullary hematopoiesis. So what are the four ways the bone marrow expands? It expands by being hypercellular. It expands by extending into the appendicular skeleton. It expands by being in places other than it should be. So those were the three ways of expansion. If I said four, I was wrong. Let's talk about the mother of all myeloproliferative diseases, and probably the most common one, called chronic myelogenous leukemia. Now, even though the L stands for leukemia, it's not at all like the regular acute leukemias we'll be talking about. It's regarded as a relatively benign proliferation of all of the cell types of the bone marrow. And the most obvious expansion in the peripheral blood are the granulocytes. But in CML, you'll also have increased platelets very often. In CML, you'll also have increased red cells very often. Now, we said that it does not behave like an acute leukemia, but, we'll say about 20%, and the reason why it's hard to give an exact number, it depends on time, more than a couple percent, let's say 20% of the CMLs can develop into an acute leukemia, in which you now have blasts in your peripheral blood. That's the definition of acute leukemia, is blast cells in the peripheral blood. So whenever a person with a chronic myelogenous leukemia develops more than about 10% or 20% blast cells in the marrow or in the blood, that's called a blast crisis. It's usually in adults, okay? And there's a very specific genetic or chromosomal defect which has been known, for many, many years, and it's called the Philadelphia chromosome. And the Philadelphia chromosome is an aberration in which chromosome number 9 has a translocation with chromosome number 2. So the BCR of number 9 and the ABL of 22 fuse. And this is called the BCR-ABL fusion. And even though we've known about the Philadelphia chromosome, which is present in the vast majority of cases of CML, it is now greater knowledge of the BCR-ABL fusion, which has allowed us to make extremely significant improvements in the management and sometimes even cure, if I dare use the C word, cure. Knowledge of this fusion has made a massively great influence on the prognosis and treatment of the disease. Now, we said that in CML, the marrow is usually around 100% cellular, not 50%. We said it's not just granulocytes, it's all cell lines are increased. Just like in P. vera, another myeloproliferative disease, all cell lines are also increased. And if you remember, we said the normal ME ratio is about 3 to 1. Well, if you're having a significant or primary increase in the granulocytes, your ME ratio is no longer about 3 to 1. It could be 10 to 1. It's going to be 5 to 1, 10 to 1, maybe 20 to 1. And also remember, we said that your normal neutrophil count was, let's say, if the total white count was, let's say, 6 to 11,000, then the normal neutrophil count, being 2/3 of those, was, let's say, 3,000 or 4,000. So it's not unusual to have mature neutrophils in the peripheral blood 10 or 20 or 30 times as high as normal. So you have a patient with mature granulocytes being 50 to 100,000 rather than 4,000 or 5,000. Then you can probably diagnose CML very, very confidently. But remember, there should not be an increase in blasts. Whenever CML has more than 10% blasts in the peripheral blood, then it's not CML anymore. It's something that's going into acute leukemia, or what they call blast crisis. And not only are there increased blasts in general, though, normally there should be no blasts in the peripheral blood. You could have a few up to 10% blasts in chronic leukemia, but if it gets over 10 or 20, you can say that's an acute leukemia now. Also remember that it's one of the commonest causes in this country, USA, for very, very, very massive splenomegaly. It's not unusual for patients that have CML to have spleens that are as big or bigger than the liver. So if the liver is normally 1,500 grams and the spleen is normally 1/10 that size, 150 grams, it's not unusual to have a spleen that's bigger than 1,500 grams. And also remember, we said this before, I'm excited about it, that's what I'm saying again, is that knowledge of this specific enzyme, the BCR-ABL kinase, which is one of the big things causing that chromosomal aberration. Now that we can inhibit it with specific inhibitors, this disease has now, I'm very proud to say, about a 90% remission rate. Isn't that spectacular? Here's the bone marrow. And even if you didn't want to spend a lot of time figuring out what all these cells are, the one thing you can say is that there's no fat. I mean, this is not fat. That's a blood vessel. That's a blood vessel. Remember, a normal bone marrow is 50% fat. Well, this is 0% fat. This is a 100% cellularity marrow. And you can see, if we were to go under the microscope and look at these, most of these cells are in the myeloid series. And rather than having a 3:1 ME ratio, we might have a 10:1 or a 20:1. But look, see all these big cells? Well, you know those are megakaryocytes. We got one here and here and here and here. There's about 15 megakaryocytes, big cells in this field. Because remember we said in CML, not only are the whites, the myelocytes increased, but also are the megakaryocytes. So somebody with CML can also have significantly increased platelets as well. Here's another picture. And in fact, here's an area in which there's a lot of megakaryocytes together. And I know what you're thinking. You're probably thinking, well, Dr. Minarsik, if the whole bone marrow looked like this, wouldn't that probably be better termed essential thrombosthenia if the primary peripheral expression was increased platelets? And the answer is yes. However, in this particular bone marrow, it's from a CML, the primary peripheral expression just happened to be neutrophils. But I just want to show you that even though it's called chronic myelogenous leukemia, the increases in all the cell lines, usually. Just remember, do you remember when we did the chapter on red blood cells, we talked about P. vera, and we said P. vera is a lot like CML because it's not just red cells that are increased, polycythemia, and they're not increased for physiologic reasons like altitude or dilution or all those other things that might cause a physiologic increase. This is a true increase. This is vera. This is truthful. So polycythemia vera, another myeloproliferative disease, all cell lines increased, not just RBC, but the primary expression is red blood cells. There's probably also increased platelets and increased white cells like in my CML. And because there's a lot of marrow turnover, remember, there's a lot of purine metabolism going on. Patients with P. vera get gout. They get thrombosis. Why do they get thrombosis? Well, because there's increased platelets. You think patients with essential thrombocythemia, the other myeloproliferative disease, also get thrombosis? Hell yes. And also remember, not only do they get increased thrombosis, but they can also get the opposite of thrombosis, increased bleeding. Because even though they may have increased platelets, the platelets can be very likely to be abnormal. So you can have like 500,000 platelets, but they're not normal platelets, so the patient bleeds. Now, whereas CML about 20% of the time goes into a blast crisis, P. vera patients do generally not go into a blast crisis. But they can all progress, all the myeloproliferative diseases, whether it's CML, whether it's essential thrombocythemia, whether it's polycythemia vera, they can also progress to myelofibrosis, in which the picture in the marrow is basically fibrosis. And once you have fibrosis in the marrow, a true myelofibrosis, you're also at an increased risk for acute leukemia as well. Here's a P. vera marrow, and it's not unusual. It's not 100% cellular here, but it's probably 80 or 90. In fact, you know, at this point, I think I'm going to ask an opinion here, because you guys are better at this than I am. I'm going to ask, what percentage of this cross-sectional field is fat? I know you're all going to say less than 50. And also, you know, you're all going to say more than 5. So I'm getting responses here from 15 to 10 to 49. That's good. Okay, thank you. But you see, not only is it increased cellular, just like the CML, CML is usually 100% cellular. P. vera usually isn't 100%. You can also see that the predominant cell are the white cell precursors, but also the megakaryocytes. Now here's another picture here. I don't know why I put this one in, but if you were to be looking at this as a smear or identifying the cells, you would see that all the cell lines are increased like CML, megakaryocytes. But the ME ratio now might not be as high as in the CML, because the CML, the prominent peripheral expression is granulocytes, whereas in P. vera, the prominent peripheral expression are in red blood cells. So there'll be a lot of increase of red cell precursors, normoblasts. And all of those little dark cells that have very round and very dark nuclei there and here, they're red cell precursors. The white cell precursors usually have more of an open nucleus, like there, and like there, and like there, and like there. But most of those small dark red cells are red cell precursors. So it looks like the ME ratio may even be reversed in this field. It seems like there's a hell of a lot more red precursors or erythroid relative to the myeloid. Okay, let's talk about the next one, essential thrombocytosis. A good general rule is if the normal platelet count is, let's say, 100 to 300,000, if you have elevations over 300,000 but less than 1,000,000, that's probably a physiologic reason for having increased platelets or thrombocytosis. But once those platelets go up over 1,000,000, the reason is probably myeloproliferative. And the primary myeloproliferative disease resulting in the primary peripheral expression of increased platelets is called essential thrombocytosis. It's also called essential thrombocythemia. Now, if you Google those terms, I bet you'd find that they're both used a lot. I don't know which one is used more. I'd say it's about 50-50, but I'm sure somebody's going to win out. And very often it's a diagnosis of exclusion, because you see an increased amount of cellularity in the marrow, and the primary peripheral expression is platelets, usually over 1,000,000 or around 1,000,000. So that's how you make the diagnosis. Of course, if you look at the marrow and you see that there's megas all over the place, megakaryocytes, it's the rarest of all myeloproliferative disorders. I've only seen 3 or 4 cases in my life. I've probably seen 100 cases of CML. I've probably seen, 30 cases of P. vera. Now, here's an interesting concept also. What if you were to do a automated count on this person's CBC, and it gave you a RPW? Now, remember, an RPW is a measure of the variation in platelet size. It's expressed as a coefficient of variation. Just like an RDW is a measure of variation in the red cell size, or we call anisocytosis. There's also a number called an MPV. An MPV is to platelets exactly what an MCV is to red cells. An MCV is a measure of the volume of the red cell. An MPV is a measure of the volume of the platelet. Now, usually in essential thrombocytosis, the platelets are bigger. They have bigger volumes. And why would platelets be bigger with essential thrombocytosis? Well, let's use the analogy again of the red cells. When red cells are released from the marrow in increased numbers, they're generally bigger. They're still reticulocytes. They have they're a little bit more basophilic. They're not as red as usual. And they're bigger than usual as well. Well, the same is true with platelets. Whenever platelets are released in significantly increased amounts, they're generally likely to look a little bit bigger. So an increased MPV is also a feature of essential thrombocytosis. Now, what do you think the marrow is going to look like with essential thrombocytosis? You know that in CML we saw increased megakaryocytes. You know that in P. vera we saw increased megakaryocytes. So what do you think we're going to see in essential thrombocythemia? This is not a slice or a surgical or a cut section with H&E. This is a smear, okay, in all of these cells here. 1, 2, 3. There's probably 100 in this picture. These are all megakaryocytes. So they are massively increased. Okay. Let's get down to the last and the also one of the most likely to go into leukemia types of myeloproliferative disease. It's called primary myelofibrosis. And it's very easy to diagnose because the marrow is hypercellular, all right, but by this time, largely it's fibrotic. It could be like 50% collagen. You do a trichrome stain, it's all green. And also, with respect to the rest of the myeloproliferative diseases, it's usually an older age group, well beyond the 60s. So, for that reason, it is often thought of as being the sequelae or the natural history of the other myeloproliferative diseases. Okay? Another thing to remember is that about 10 to 20% of those can progress to acute leukemia also. So, CML can go into acute leukemia, or CML can go to myelofibrosis, and the myelofibrosis can go to acute leukemia. P. vera doesn't go into acute leukemia, but it could go into myelofibrosis, and then the myelofibrosis can go into acute leukemia. Essential thrombocythemia does not go into acute leukemia, but it goes into myelofibrosis, and the myelofibrosis goes into leukemia. And the concept of leukoerythroblastosis is not really specific for myelofibrosis, but all that means is that the marrow is packed with so much fibrosis and cellularity that the cells that you see in the peripheral smear are generally a lot more immature that you would normally see. Do you remember we talked about the concept of myelocystic anemias? And we said that a myelocystic anemia was an anemia in which you have things like tumor cells just packing into the marrow, and therefore the cells are released more early than they should be. Well, it's the same concept. In fact, they're identical terms. Leukoerythroblastosis, any condition of the marrow which is usually associated with hypercellularity or increased content of something, even fibrosis, which results in premature releases of earlier cells into the peripheral marrow. Here's a nice primary myelofibrosis. And look at, there's probably a bunch of megakaryocytes, but look at, that looks like it's more than just those delicate white and red cell precursors surrounded by reticulin fibers. This is fibrous tissue. So you do a trichrome on this and you're going to see a lot of green, aren't you? Now, you know, the one thing I did not mention is that I told you that the third way that a marrow can expand is by producing marrow in organs other than bone marrow, like spleen, like liver, like lymph nodes. Those are the three commonest areas. Well, this particular form of myeloproliferative disease, myelofibrosis, is very often, in fact usually, associated with the term myeloid metaplasia, which also means extramedullary hematopoiesis. So in other words, you're making blood cells in places other than the marrow. So by that sense, it's a metaplasia, isn't it? But it's also called extramedullary because it's beyond the marrow. So does myeloid metaplasia mean exactly the same thing as extramedullary hematopoiesis? Yes. Okay. We've covered a lot today. Let's see where we are here. We could probably get a nice start into the so-called concept of leukemias now. We've covered the myeloproliferations, some of which are associated with leukemias. We talked about normal structure function. We talked about the reasons for increases or decreases of the different cells. Let's talk about the malignant proliferation of blood cells, which is the exact definition of leukemias. That's the definition. Now, any condition which results in uncontrolled malignant proliferation of white blood cells is called a leukemia. They all start out in the marrow because that's where the cells are made. But they involve the peripheral blood as well. So these leukemic cells can infiltrate lymph nodes, they can infiltrate brain, liver, anything which receives blood. That's logical. Now, here's something that you also have to understand. Even though all the blood cells are made in the marrow, both the lymphoid cells as well as all the other cells in the non-lymphoid line of cells, the leukemias of lymphocytes are classified in intimate connection with the malignant lymphomas as well. Because when we talk about malignant lymphomas, we're talking about malignancies of lymphocytes within lymph nodes. When we talk about lymphocytic leukemias, chronic or acute, we're talking about proliferations of lymphocytes that may have started out from lymph nodes, or they may have started out from the bone marrow. So there is no way you could talk about lymphocytic leukemias, either acute or chronic, without understanding that they have to be classified with the malignant lymphomas as well. So let's talk about the concept of leukemias versus lymphomas. Sometimes the lymphomas are generically given the term lymphoproliferative disorders. Sometimes the word lymphoma is preceded by the word malignant, which is redundant because all lymphomas are malignant. Now, all leukemias of lymphocytes, acute leukemias, chronic leukemias, they all have lymphoma counterparts. Okay? Now remember, even if you have a primary lymphoma or malignant lymphoma, those cells can spread into the peripheral blood. So when you have a marrow, let's say, that's relatively free of increased lymphocytes or malignant lymphocytes, and your primary malignancy of lymphocytes is from your lymph nodes or other lymphoid organs, these lymphocytes can then enter the blood, and it's called a leukemic phase. So a leukemic phase of a lymph node, of a lymphoma, is a leukemia. And also remember, multiple myelomas, or malignant proliferations of plasma cells. Aren't plasma cells derived from lymphocytes as well? Yes, but nobody would ever call a multiple myeloma a lymphoma, even though plasma cells are the result of B lymphocyte differentiation. Now, here's another point to remember. Any myeloid leukemia or lymphoid leukemia, it can infiltrate into a lymph node. So when you have a myeloid or a non-lymphocytic leukemia involving a lymph node, you simply call it myeloid infiltrate into a lymph node. You would not call it a lymphoma. Lymphomas are only malignant lymphocytes. And also remember, all lymphomas are malignant proliferation of lymphocytes. They could be called by a wide variety of names, old names, new names, but in malignant lymphomas, it's only lymphocytes that are malignant. Another thing to remember is that all leukemias involve bone marrow changes. Certainly, all of the myeloid or non-lymphocytic leukemias you will see the increases in malignant cells in the bone marrow well before they may even appear in the peripheral blood. But even in lymphocytic leukemias, whether they start in the bone marrow or whether they start in a lymph node, they'll all eventually involve the bone marrow as well. So, the lymphocytic leukemias, they start where lymphocytes develop, in lymph nodes and in marrow. If they start in the lymph node, they can spread to the marrow. If they start in the marrow, they can spread to the lymph node, or they can start in both places. You know what, I'm going to take a break in a minute, but I'm going to make one comment before we really get into the malignant lymphomas. Pathologists hate lymphomas. Okay, I'll tell you why. Because, you know, I went to medical school in the late 60s, the early 70s, and now here we are, what is that, 40 years later? Okay. During those 40 years, the classification of lymphomas has undergone upheavals and total changes about every 10 years. So all my friends and I, we go to conferences and we learn about the latest classification of lymphomas. Then a few years later, we have to learn it all over again. They're always constantly changing the classification. Generally speaking, they're changing them for the good. But for pathologists, non-pathologists, and even pathologists, the classification of lymphomas is a big nightmare. So what I've done for the last several years, and what I'm going to do, is take away the nightmare for you. And I'm just going to talk about adjectives rather than specific lymphoma classifications, because it'll just cloud your mind. So lymphomas can start in lymph nodes, or they could start in areas besides lymph nodes that have lymphocytes. You know, like a spleen, for example. So lymphoma can be nodal or extranodal. You know, there's two kinds of lymphocytes, T cells and B cells. So you can have a T cell lymphoma, you can have a B cell lymphoma. Most of the lymphomas overall are B cell lymphomas. The lymphocytes can be small, you know, your standard 10 micron nucleus small lymphocytes, or they could be large. It could be 15 or 20 microns on the average. The lymphomas inside of a lymph node can have a round follicular appearance like lymphoid follicles, or it could be diffuse. Okay? Lymphomas can be Hodgkin's lymphomas, in which you see Reed-Sternberg cells, or they could be non-Hodgkin's lymphomas, in which you don't see Reed-Sternberg cells. And most of the lymphomas are non-Hodgkin's. Now, for the longest time, we had the so-called FAB classification, which stood for French, American, British. It seems like that was really cool because it was classified ultimately into prognostic categories. And nobody really talks about the FAB classification anymore. They generally talk about the so-called international classification, which evolved from the FAB and is very similar to it. So by no means would I sit here today and tell you people all over the world that FAB is international, because all it is French, American, and British. Okay, let's take a break. It's about almost 10. We covered a good amount. What we're going to do, now that we've differentiated the concepts of lymphomas and leukemias, we're going to talk about the leukemias when we get back, and then we'll talk about the lymphomas if we have time. So this would be a good time for me to pop down the window, and I could probably take a quick look at the question box to see if somebody said anything spectacular. If not, you got a second now to do it. No, I don't see anything. So I'm going to play a song now, 3 songs, and the first one, I think, if you've been reading the news, is probably very, very, very appropriate.
If should stay, I would only be in your way. So I'll go, but I know I'll think of you every step of the way. And I will love you. Bittersweet memories, that is all I'm taking with me. So goodbye, please don't cry. We both know I'm not what you need. Treat you kind, and I hope you have all you dreamed of, and I wish you joy and happiness. But above all this, I wish you love.
I was a highwayman, along the coach roads I did ride, with sword and pistol by my side. Many a young maid lost her baubles to my trade. Many a soldier shed his lifeblood on my blade. The master 25, but I am still alive. I was a sailor, I was born upon the tide. With the sea I did abide. I sailed a schooner around the Horn of Mexico. I went aloft and furled the mainsail in a blow. And when the yards broke off, they said that I got killed. But I'm living still. I was a dam builder across the river deep and wide, where steel and water did collide. A place called Boulder on the wild Colorado. I slipped and fell into the wet concrete below. They buried me in that great tomb that knows no sound. But I am still around. I'll always be around and around and around and around. I fly a starship across the universe divide. And when I reach the other side, I'll find a place to rest my spirit if I can. Perhaps I may become a highwayman again. Or I may simply be a single drop of rain. But I will remain. I'll be back again and again and again.
I wish you had button eyes and a red felt nose, shaggy cotton skin and just one set of clothes, sitting on the shelf in a local department store, with no dreams to dream and nothing to be sorry for. I wish I was a teddy bear, not living or loving or going nowhere. I wish I was a teddy bear, and I wish that I hadn't fallen in love with you. I wish you had a wooden heart and a sawdust
we're back. We had 3 nice songs during the break. I didn't have any spectacular inspirations during my recaffeination period, but I did want to ask you again a little question. Was everybody able to hear me well during the first hour? Were there any blackouts or anything like that? Okay, that's what I thought. Just always want to make sure to satisfy my little insecurity. Once again, you know, I'm having a real ball doing this chapter. It is such fun to do the WBC and RBC chapters, and if I was to give all my pathologist friends the chance to talk on one of the 29 chapters, they would probably all pick RBC or WBC. And once again, the problem is not in figuring out what to say, it's figuring out what not to say, because we all have, this is one of the few areas we have like really, really big knowledges on, and we don't want to snow you with everything we know. We want to filter it into everything we think you should know. It's a dangerous feeling whenever there is a chapter that you're very well familiar with, because you feel, oh, I don't have to review for this. I know this off the back of my hand. And then you wind up stumbling simply because you didn't prepare properly. So even though I love this chapter and I like it and I feel like I don't have to get any new knowledge, I think we always have to prepare it in such a way that it's more digestible for you. Okay, let's continue it. I'm having fun today, as you could tell, what I usually do. I think that now that we have made the differentiations between lymphomas and leukemias and concepts, let's talk now about the leukemias. Now, there's a lot of adjectives for leukemias. There's a lot of classifications, too. Let's talk about the adjectives. I like the word adjective rather than classification. Leukemias can be acute or chronic. And remember, leukemias could be of any blood cell. They could be not only just of granulocytes or lymphocytes, you know, technically of monocytes, you know, of megakaryocytes, of red cells. These are all leukemias. Now here's the differentiation between acute and chronic. An acute leukemia has blast cell increases in the bone marrow and in the peripheral blood to make it an acute leukemia. A chronic leukemia may have a little bit of an increase in blast cells in the marrow, but usually not too many blast cells in the peripheral blood. In most of the acute leukemias, practically the whole marrow is packed with blast cells. Okay, the common leukemias are called either M or L, you know, myeloid or lymphocytic. Myeloid are the cells, technically granulocytes, and lymphocytes are lymphocytes. Now, if you remember in our differentiation from basic cell biology in the bone marrow, there's 2 lines of differentiation in the marrow. Ones are the lymphocytic lines, and the other line is everything else. So if you remember those little arrows on your little diagram, the so-called myeloid line of differentiation, it was not just granulocytes or neutrophils. It was eosinophils, it was basophils, it was monocytes, it was erythroid cells, and it was also platelets and megakaryocytes as well. So that's why the so-called myeloid leukemias are classified according to one of those primary elements, whereas the lymphocytes are just lymphocyte leukemias, chronic or acute, are just lymphocytes. You can have leukemias as a kid or as an adult, technically any kind, but most of the chronic leukemias are in adults and even older adults. And the most common type of childhood acute leukemia is lymphocytic, but it could be myeloid as well. All leukemias involve the bone marrow. In most of the acute leukemias, the prominent cell in the bone marrow are blast cells. And because these malignant proliferated blast cells practically fill up the marrow, they suppress normal hematopoiesis and thrombopoiesis. So the clinical presentation of most of the acute leukemias are anemias, and thrombocytopenias. The kids or the adults look as pale as hell, and they also often spontaneously bleed because their production of platelets is being suppressed. Most of the leukemias have very well recognized specific chromosomal aberrations. We talked about the so-called Philadelphia chromosome with chronic myelogenous, but the other ones often have very predictable aberrations, and sometimes they don't. Some of the leukemias can drastically respond to chemo. Some of them don't respond very well. In general, the childhood leukemias generally respond better than the adult leukemias. And I want to tell you some other really good news. The childhood lymphocytic leukemias are usually cured. We couldn't have said that a generation or two ago, but we can say it now. Now, here's the most important thing you have to know visually. You absolutely have to know what a blast cell looks like, and you're not getting out of this room alive until you can tell me what a blast cell looks like. Blast cells are all bigger than any other normal cell in the blood, whether it's a nucleated cell or whether it's a red cell. And in addition, a blast cell has absolutely no cytoplasmic granular differentiation. There's no granules. The third thing is all blast cells have nucleoli. Now, I know what you're thinking. You're saying, well, nucleoli are supposed to be dark. Why are these three structures white? Well, remember, this is not the H and E stain. This is the right stain, which is something like the Giemsa stain. So most of the great stains to differentiate and identify blood cells are not regular H and E stains. They're right stains. They're the kind of stain that you see, you know, when you get your blood smear. And on the right stain and on the Giemsa stain, the nucleoli are lighter than the rest of the nucleus. Whereas on the regular H and E stain, nucleoli are almost always darker. So the reason why you have to know what a blast looks like, the techs are much better than this than we are, is that if you do smears in your office and you see even one blast cell on that patient's blood film, you have to strongly consider that there may be a developing acute leukemia. And the early recognition of it can save your patient's life. And if you don't recognize it, you kill your patient. It's as simple as that. Let's talk about other general features of leukemias and lymphomas. They're generally referred to as the hematologic malignancies. And remember, they generally, not only the leukemias, but the lymphomas, have very often general predictable chromosomal translocations. They can have other genetic and chromosomal abnormalities, but a chromosomal translocation is the most common type. If you remember, we talked about Down syndrome, where they have the extra chromosome 21, or we talked about another genetic disease called Fanconi's anemia, which is an aplastic anemia that's hereditary. We also may have mentioned a disease called ataxia telangiectasia, and it's properly named because the patients are ataxic, like they have cerebellar disorders, and they have dilated blood vessels in their skin and other areas, the telangiectasia. And it's also a genetic disease. Well, these are all diseases that have a very high association with leukemias and lymphomas. And what about, you know, HIV? Do HIV patients get lymphomas? Yeah. Do patients with viral diseases like Burkitt's lymphoma caused by EBV, is there association between viruses? Yeah. And remember, before HIV was called HIV, it was called HTLV3, because there was a disease called HTLV1 which caused a human lymphoma. So the actual virus now HTLV3 we now know as regular old HIV. And also remember that you can have human herpes virus 8 causing Kaposi's sarcoma in AIDS patients, as well as B-cell lymphoma. So these are the general common viral and genetic strong associations. What about bacteria? We have this little bug now that we know causes almost all of the duodenal and gastric, ulcers, the peptic ulcers, called H. pylori. Well, guess what? H. pylori causes gastric lymphomas too. Now, I know what you're thinking. You think, how can you have a lymphoma of the stomach? The stomach is not a lymphoid organ. Well, remember, we have something called MALT, mucosal associated lymphoid tissue. Half of the lymphoid tissue in our body is not in lymph nodes, it's in mucosal and submucosal areas. So maltomas of the GI tract are caused by bacteria, H. pylori, the same bug that causes ulcers. So now most ulcers are not treated surgically, they're treated with antibiotics against H. pylori. Patients that have a sensitivity to gluten, also called celiac disease, one of the most common causes for primary malabsorption in the small bowel, well, they have a strong association with T-cell lymphomas. Isn't that interesting? Also remember, patients that are HIV positive and full-blown AIDS, they frequently get B-cell lymphomas. Now, although HIV primarily infects T cells, although we know now it affects everything, but primarily T cells, the malignant lymphomas that AIDS patients get are usually B-cell lymphomas. And in general, B-cell lymphomas are more common than T-cell lymphomas everywhere anyway. Also, patients with HIV also get primary malignant lymphomas of the brain. Before the HIV epidemic, we never saw a primary lymphoma of the brain. Now, when an HIV patient comes in with a brain lesion that you pick up on MRI or CT, most likely diagnosis is a CNS lymphoma. Second most likely diagnosis would be toxoplasma infection of the central nervous system. Okay, where's a good place to start? If you look at the general matrix, you have acute and chronic, you have lymphoid, and you have myeloid. Those are your four possibilities. So let's start out with acute lymphoid or acute lymphocytic lymphoma. And it's really there's no much of a difference in the clinical presentation of an acute lymphoid from an acute myeloid leukemia. Acute lymphocytic leukemia, also classified with the lymphomas. Okay, because the patients with acute lymphocytic leukemia, it's a rather sudden onset, because those blast cells are decreasing the production of red cells and platelets. They're very anemic. They often bleed spontaneously. If you remember, when platelets get below, let's say 25,000, very often there's spontaneous bleeding. And they get fevers as well. Patients with acute lymphocytic leukemia, like acute myelogenous leukemia, they get bone pain, they get adenopathy, they get increased size of the lymph nodes, adenopathy. That might be because they also have a lymphoma, or it could be because the cells infiltrated into lymph nodes. They also get enlarged livers, enlarged spleens. These are all common features of all the acute leukemias, but with the lymphocytic, these are three that are much more common than in the other ones. They can also get headaches, vomiting, nerve palsies. These are all due to infiltrations of the malignant leukemic lymphoblasts within various tissues. So a lymphoblast is the malignant proliferative cell of acute lymphocytic leukemia. They could be T cells They could be B cells, but they really haven't differentiated very much yet either. They could be very, very primitive and have not differentiated into T or B yet, because a blast cell, by definition, is a cell which is undifferentiated. We also said, and this is about the fourth time I'm saying it, because it was not always this way, is that you can talk about the acute lymphocytic leukemias, but in all of the classifications, they have to be talked about with relationship to lymphomas as well. ALL is mostly in children. It could be in adults, but most of them are in kids. They have sometimes very specific chromosomal changes. They can have hyperploidy, okay? And very often they have the Philadelphia chromosome. They can have translocations. But here's the good news. Acute lymphocytic leukemia in kids, 90% of them respond to the newer chemotherapies. So they're 90% remission. And guess what? Most of those remissions are permanent. So would it be fair to use the big C word and claim that most of the acute lymphocytic leukemias, which are mostly in kids, are usually cured? Well, I know that sounds like heresy, but the answer is yes. This is a typical picture of an acute lymphocytic leukemia. Remember, it's going to involve lymphoblasts in the bone marrow. Here's a bone marrow that's 100% cellular, and they all look like they're the same kind of cell. And if you look at those cells, they all look like sort of like lymphocytes. Maybe you'll find some nucleoli. But remember, and I'll say this a million times, a blast is a blast is a blast. So technically, does a lymphoblast look any different than a myeloblast? Well, some people will tell you yes, but once again, a blast is a blast is a blast. A blast is a big cell with no cytoplasmic differentiation and often see one or more likely more than one nucleolus. So you see a marrow infiltrated with lymphoblasts, and there's these cells in the peripheral smear looking like blasts. It's an acute leukemia. And if you do markers, perhaps, to show that these cells are of the lymphocytic line rather than the myeloid line, then you have cinched your diagnosis. Okay, well, now that we've talked about the acute lymphocytic leukemias, let's talk about the chronic lymphocytic leukemias. And remember, we said the chronic myelocytic leukemias were really more myeloproliferative diseases. They're not really a true leukemia, but they can go into a true blastic leukemia. Well, I think you might say the same thing for CLL, except it doesn't go into a blast crisis, but it can progress in terms of marrow involvement. So what is chronic lymphocytic leukemia? Well, one thing it's probably the most common reason for a tech in hematology to bring a slide to your attention, because there's increased lymphocytes. So if you know how to identify a normal, mature lymphocyte, then you know how to diagnose CLL. You don't even have to do a bone marrow. You don't have to do special stains. It's strictly a mathematical definition. So if you know that the normal white cell count is, let's say, once again, let's say 5 to 10,000 or 6 to 11 or whatever you want to call it, and lymphocytes should only be about a third of that, then you also know there should only be like maybe, let's say no more than about 1,000 or 2,000 lymphocytes totally, your absolute lymphocyte count. But if you take a person over the age of 60 and they have more than 4,000 lymphocytes, normal, mature-looking lymphocytes, sustained, in other words, for a period of several months, then you could diagnose CLL. Does that sound ridiculously simple? They're normal lymphs. There's more than 4,000 of them. In an older person, I mean older than you, not older than me, after age 60, you can diagnose CLL. And usually men are a lot more likely, oh, not a lot more, but let's say about 2 to 1 than women. And remember, the cells look normal. They're not blast. They don't have nucleoli. They look like normal lymphocytes. And technically speaking, at that point, you wouldn't even have to do a bone marrow exam because that's the diagnosis. Now, if you do the bone marrow exam, you might see some increase in lymphocytes in the bone marrow too, but it might not be much of an increase. However, as the disease progresses, the amount of marrow involvement increases, the amount of infiltration into lymph nodes increases, and the amount of infiltration into the liver and spleen might progress as well. And this is still if it's in the chronic phase. And remember, it doesn't go into the blast crisis like CML does. Now, if it goes into the liver, it could involve the portal triads, or it can involve the sinusoids. Well, there's really no other place it can involve, so that was kind of a stupid thing to say. And the thing is, with CLL, when you do the chromosomal studies, it's not very often to have a translocation, like you do with CML, but very often you see trisomies, okay, an extra chromosome, and also deletions in the tumor cells as well. Here's CLL. You put your patient slide under the microscope and you say, gee, it looks like these lymphocytes are increased. Maybe they're even more than the granulocytes. Rather than being about 1/3 of the granulocytes, maybe they're 3 times as many as the granulocytes. But look, you still have platelets. You don't see nucleoli. They still look like classic lymphocytes. So if you know how to identify normal mature lymphocytes, and you could see that they're increased in absolutely over 4,000, you got your diagnosis. And remember, if this was an acute leukemia, what's the one thing that you see in this field that you wouldn't see with acute leukemias? You wouldn't see this many platelets. Very often platelets are greatly reduced. Another feature is that, a lot of times when you do a blood smear, some of the cells can sort of smush. They call these smush cells or fragment, or look like little baskets. But for some reason, even though these look like normal lymphocytes, they're a little bit more fragile than normal. So very often when you smear those cells onto a slide, they tend to look like basket cells. So when you see, you know what, almost every smear you look at, you might see a couple of cells that look like this. But when you see a lot, and then you see a lot more cells that look like lymphocytes, and they don't have a nucleolus, and there's normal platelets, you can diagnose CLL. What else can we say about CLL? Well, they're hypogammaglobulinemic. Now, why would they be that? Well, do you remember what kind of cell gives rise to the cells which make gamma globulins? The plasma cells? Yeah, it's the B lymphocytes. So if your B lymphocytes are not functioning well, you can overall expect a hypogammaglobulinemia very often. And also, very often, patients with CLL will have autoantibodies against their own red cells and platelets as normal. That's another observation. I don't know if anybody can explain this. And once again, even though we're talking about chronic leukemias, you have to still consider them to be in that family of lymphoproliferative disorders. In other words, lymphomas as well. Let's talk about a special kind of malignant proliferation of a B cell product called a plasma cell. Malignant proliferations of plasma cells is the definition of multiple myeloma. And they're primarily in the bone marrow because that's where plasma cells often differentiate from B lymphocytes. They don't occur, you don't get multiple myelomas of the lymph nodes, although you can have malignant lymphomas in which the cells look a lot like plasma cells. So we defined multiple myeloma as malignant, uncontrolled proliferation of plasma cells, and sometimes those plasma cells can actually be picked up in a peripheral smear. Now, if you know what a plasma cell looks like, and you see a plasma cell or 2 or 3 on a peripheral smear, you can be very, very suspicious that that's part of multiple myeloma. but almost all of the expression of a multiple myeloma is in the bone marrow, okay? And usually, not only is there a tremendous increase in plasma cells, but there's a tremendous increase in the substances which plasma cells produce, antibodies. So monoclonal gammopathies. Remember, antibodies have heavy chain, light chains. Sometimes these tremendously increased parts of antibodies, the light chains, are actually go into the urine, and they're known as Bench-Jones protein, and there's a very easy test for that, but probably nobody does it too much anymore because there's a lot more specialized tests. Also remember, patients with multiple myeloma usually have an elevation of interleukin-6, or let's say not usually, but when they do, it's a bad prognosis. So that's a nice prognostic sign. So at this point, let's look at a plasma cell. Just like I'm not going to let you out until you know what a blast looks like, I'm not going to let you out here until you can absolutely know in your sleep what a plasma cell looks like. All plasma cells have a round nucleus, and almost all plasma cells has an oval cytoplasm. And the chromatin is often dispersed or densest at the edge of the nucleus, what they call the cartwheel or clock face, because it looks like there's a bunch of numbers in the clock that are along the edge. And even though the cytoplasm is oval and the nucleus is round, the nucleus is usually at the edge of one of the oval mass of cytoplasm. And between the nucleus and the wider lip of cytoplasm, you'll often see a clear area. Well, that's Golgi. That's the Golgi apparatus. That's the place that normally stores antibodies. And if this is a malignant cell producing too much antibodies in an uncontrolled fashion, you'll very often have a very prominent Golgi. Sometimes they call this the HOFF, H-O-F-F. I've heard a few other words, but that's all. It's a perinuclear clear zone in plasma cells. Now you can see plasma cells in skin. You could see plasma cells on EM. You could normally see a couple of plasma cells in the marrow, probably no more than a couple percent usually. But when your bone marrow gets to be more than about 20% plasma cells, it's almost always multiple myeloma. Or even if it's less than 20%, but you see sheets of plasma cells like this, in which everything is a plasma cell, that's very, very suspicious as well. Now, let's talk about an interesting concept. Do you remember we told you from day one that the more malignant a cell is, the less likely it looks like its normal counterpart? Well, fortunately for us, to make the diagnosis of multiple myeloma, the plasma cells that we identify almost always look like normal plasma cells. Now, there are a few ways to classify plasma cells, and some of the bad ones don't look very much like plasma cells at all. But almost all of the malignant proliferations of plasma cells, the so-called plasma cell dyscrasia, and almost always in medicine when you hear the word dyscrasia, the word plasma cell is in front of it, and that just means multiple myeloma or malignant proliferation of plasma cells. Now, I'm going to pop out the window because I have a very, very important question to ask you, and I think you'll get it right. So here is the question. Let's say you had two kinds of myelomas, malignant myelomas, or multiple myelomas, which are all malignant. In one type, the plasma cells look like normal plasma cells, and in a lesser differentiated type, they don't look very much like plasma cells at all. Well, here's the question. Which type of myeloma is going to secrete more monoclonal antibodies? The well-differentiated or the poor differentiated? Yes, absolutely. That's the whole principle of pathology again. Because the more a cell looks like it's supposed to do, the more a cell will be doing what it's supposed to do, and that's making antibodies. And here are the antibodies that it makes. Now, this is a normal serum protein electrophoresis on the left. Here's your albumin. Here's your acute phase reactions, the alpha 1 and alpha 2. Here's the beta fraction. Usually, the albumin is always the biggest, and it's a pretty sharp spike. But the gamma fraction, which contains primarily your antibodies, your gamma globulins, is usually very wide. Okay, it's because it's a wide variety of protein substances. And it's usually the second biggest thing. Alpha 1 is usually the smallest thing. And alpha 2 and beta are usually in between. Now, I don't know if you people have gone to the Batman movies or not, but if this is the normal protein electrophoresis and there's one albumin spike, but there's no second Batman here, that's a normal thing. Very often, the amount of specific monoclonal protein antibodies being produced by multiple myelomas can even surpass the albumin. So it looks like Batman. Or, I don't know, in America there's another common thing where you put up your first and your second and your fourth finger, and it's not a very nice thing to do, but this is basically the classic appearance on electrophoresis of a multiple myeloma, secreting specific globulins. They're usually gamma G and gamma G fragments. Sometimes they're gamma A, and they're usually not gamma M, because monoclonal proliferations of gamma M are generally more associated with lymphomas rather than plasmacytomas. But we'll talk about that at the end. Okay, so here's multiple myeloma. Because it's in the bone marrow, there's bone marrow destruction. It's associated with a variety of deletions and translocations. It's not really worth memorizing which ones. I think that's stupid. I think that if normally we told you there's only a couple % of plasma cells in a normal marrow, when you get over 20, it's almost always myeloma. Or if it's less than 20, let's say 5 or 10, or let's say 10 to 15. But you see a lot of those plasma cells are in sheets. That's the diagnostic pattern. The plasma cells usually look normal, thank God, because we could count them if we know what they look like. And it's more likely to have a gamma G than a gamma A proliferations, but the other ones are very, very rare. These patients have infections, these patients have renal problems, and these patients have bleeding. And remember, the protein expressed by multiple myeloma is an immunoprotein. Well, guess what? Amyloid is also an immunoprotein. So do you think that patients with multiple myeloma have a very, very high likelihood of developing amyloidosis eventually? And of course the answer is yes. Of all the diseases which cause amyloidosis, multiple myeloma is at the top of the list. If you ever get a skull x-ray on a board exam, and you see these little holes or punched out lesions, very often they'll put a picture of a skull, and you see these, the term is usually used punched out, or it's lytic lesion, because you have plasma cell proliferations actually destroying the normal density of the bone in a focal fashion. Then that's very, very classical for multiple myeloma. I guess it could be metastases as well, but more likely multiple myeloma because it's so widespread. Now, even though there are areas between these lytic lesions that don't look like they're punched out, if you were to do a bone marrow exam on this patient and stick a needle, into the posterior iliac crest or even the sternum, most likely you're going to see tremendous increases in plasma cells. Now, I know what you're thinking. You're thinking, well, what would happen if a patient had a tumor of plasma cells? Not even necessarily in the bone marrow, but in the skin, or in the muscle, or in the stomach. And they all look like normal plasma cells. But the bone marrow doesn't have increased plasma cells. You think, is this a multiple myeloma? No, technically, it's just called a solitary plasmacytoma. It's a benign tumor of plasma cells, okay? It doesn't involve the bone marrow diffusely. Now, you're going to want to ask yourself, however, this patient that has been biopsied for a little lump in his leg, that's all plasma cells, but he doesn't have any protein spike on his electrophoresis, and his bone marrow doesn't have increased plasma cells. Is this patient going to eventually develop multiple myeloma? And the answer is yes, because most of the patients with solitary plasmacytomas eventually develop full-blown, widespread marrow multiple myeloma. But that's a time factor. It might take 10 or 20 years to do it. But most solitary plasmacytomas, they won't be treated aggressively, but they'll be watched carefully. Now, let's flip the other side of the coin. And let's take a patient now that has a spike. He has a gamma spike on his electrophoresis, but there's no plasma cell proliferation found anywhere. It's called MGUS, monoclonal gammopathy of unknown significance. And you say, well, is this patient going to eventually develop a multiple myeloma too? And the answer is probably not. MGUSs are generally found in older patients. They usually do not develop into full-blown multiple myelomas. And here's some statistics. If you're 50 years old and you have an MGUS, you only have a 1% chance of having a myeloma. If you're 70, that goes up to 3%. But overall, the incidence of multiple myeloma, malignant plasma cell destructive lesions in patients with monoclonal gammopathies is pretty low. And even though the patient may have some chromosomal aberrations, like you classically see with multiple myeloma, they generally follow a benign course. Okay, now that we've opened the door to gammopathies, let's talk about them. We said that in multiple myeloma, the primary gammopathies are gamma G, without a doubt the most common, sometimes gamma A. Could a gamma E be possible, or gamma D? Yes, it could be, but they're extremely rare. But what about if you have a increase in gamma M primarily? And that's called Waldenstrom's macroglobulinemia. And it's probably called macro because gamma M is the biggest of all the antibodies, as you know, 5 times bigger than everything else. So, are these usually found with multiple myelomas? No. When you do have a monoclonal gamma M gammopathy, it's usually associated with various types of lymphomas. Also, remember we told you that the proteins of multiple myeloma often get expressed in the urine, and they're usually light chains. But let's say that you had a proliferation primarily of heavy chains. Is that a multiple myeloma? No, most likely it's also associated with lymphomas. And very often, rather than lymphomas, they'll use the term lymphoproliferative diseases, which for the most part is almost identical to the term lymphoma, of course, of which all of them are malignant. Now, what about amyloid? We said that amyloid is made out of immune proteins, accumulations, and we said that in multiple myeloma you have immune protein proliferations. What about a patient that has a buildup of amyloid? Well, we said he could very likely have had a previous multiple myeloma or even a current multiple myeloma. However, amyloid is not only found in a wide variety of chronic granulomatous diseases like fungal diseases and TB, but remember, it's also part of normal aging. So I guarantee you, I have a little bit of amyloid in my body, and so do you, but I probably have a hell of a lot more than you do. Okay, we're done with the concepts of gammopathies and plasma cell dyscrasias, and I'm going to look at the clock here, and we're making pretty good progress. I think I want to open the door a little bit now that we have a few more minutes to the concept of something we've been skirting around for a long time. We've been skirting around it because we're finally going to get to the mother lode. We talked about the chronic granulocytic leukemias as being myeloproliferative diseases, which could go into acute leukemias. We talked about acute lymphocytic leukemias. We talked about chronic lymphocytic leukemias. There's only one left, and those are the acute myelogenous leukemias, or AML. And rather than thinking of them as being purely granulocytes, think of them as being derived from that same cell line, somewhere along the line, that all of the non-lymphocytic cells are derived from. So what about the concepts of acute myelogenous leukemia? Which, of course, like acute lymphocytic leukemia, is nothing but blasts in the bone marrow, and also expression of significantly increased blasts in the peripheral blood as well. Well, they have a lot of common genetic aberrations. The bottom line is the causes of most of the leukemias, and of course the acute myelogenous leukemias, is that there's usually a genetic aberration which inhibits something which causes those cells to mature and differentiate, and therefore they build up in an uncontrolled proliferating fashion. That's the general feeling for all of the acute myelogenous leukemias and all of the acute leukemias in general. Some of them have some pretty predictable translocations, like all of the hematologic malignancies. The original FAB, remember, French, American, British, the original classification of them, which still stands, is going from M0 to M7. And I'll explain that briefly because we might not talk about it today. If you remember, every cell in the bone marrow, which is not a lymphocyte, is derived from a single progenitor stem type cell. Whether it's a granulocyte, whether it's an eosinophilic granulocyte, whether it's a basophil, whether it's a monocyte, whether it's a erythroid cell, or whether it's a megakaryocyte. And depending on the direction of differentiation, even though it may be primitive direction of these leukemias, you classify it from M0 to M7. So an M0 is a blast cell that is so undifferentiated, you have no idea what it's going into. Whereas when you go through M1, M2, M3, M4, M5, you can see it's either going into the granulocytic or the monocytic, or the mono and myelocytic, or the erythroid, or even the M7, which is the megakaryocytic leukemias. Now, here is the big thing, and any idiot can do this. If you know what a blast cell looks like, and you could say that of all the cells that you counted in the bone marrow, at least 20% of them are blast cells, because now you know how to identify a blast cell. Once you say the bone marrow has 20%, you can diagnose acute leukemia. It's as simple as that. So what's a diagnosis of acute leukemia? It's a bone marrow that has more than 20% blasts. Now normally, if you remember, a bone marrow has blast cells, or you might want to call stem cells perhaps. It's only about 1%, probably 2 at the very most. So a normal bone marrow should have about 1% blast cells, or 2 at most. But when you have 20, that's acute leukemia. Now, should we go on, or should we show you another picture? This will be the last case, and there's a yellow background because this is the classification of the AMLs. Remember, We said M1 was a cell that was so undifferentiated you can't tell what it is. If it starts to differentiate a little bit, and you see some coalescence of the aerophilic granules called hour rods, but they're rare, that's a little bit more differentiation because starting to see some nonspecific or aerophilic or primary granules. If you see one where the hour rods, which are coalesced aerophilic or primary granules, are common, you call that an M2. If you see it's differentiated all the way into the promyelocyte phase, and your primary cell of proliferation is a promyelocyte, in other words, a cell that has both granules as well as a remnant of a nucleolus, then that's an M3. If the primary cells of expression now are not only myeloid cells, but monocytes as well, because remember, myeloid cells are different from monocells, but they come from the same precursors. So your monocytes that are floating around in your blood, which go into tissue and are called macrophages, they have the same common derivation of the granulocytic cells as well. If the primary cell of proliferation is monocyte, that's called M5. If the primary cell of differentiation looks like an erythroid cell, or it may not look like an erythroid cell, you may have to do special markers to prove it, then that's M6. And if the primary cell of differentiation is in the megakaryocytic line, of course it's not going to look like a megakaryocyte, and of course you're not going to have increased platelets because all of the acute leukemias have decreased platelets. Then M7 is megakaryocytic. So I don't know, I think even though I hate to do this, I put a yellow background on here. I would want you to remember that 0 means no differentiation, 1 means rare hour rods, 2 means common hour rods, 3 means promyelocytes, 4 means a lot of myelocytes as well as monocytes, 5 is almost pure monocytic leukemia. It's also called Schilling's anemia. I'm sorry, a Schilling type of leukemia is monocytic relatively purely. M6 are the erythroid precursors, and M7 are the megakaryocytes. And remember, these cells are usually confirmed not just by the way they look under a routine Wright stain in the lab, but there's a wide variety of specific antigenic markers that will confirm your diagnosis. In the old days, we didn't have these, but we still usually got the diagnosis right 90% of the time, 95% of the time. Well, now that with special markers, antigenic markers, we've upped that percentage, hopefully close to about 100%. Okay, we're going to call it a day. It's just a couple of minutes before the hour. We're going to continue the next class with starting out with a more detailed discussion of AML, and then go into the lymphomas in the rest of the chapter. Maybe we'll finish the next lab. The next class, I'm sorry. So let's pop down the window. Let's pop open the question box. And I notice there are more people that ask questions now on chat rather than on the microphone, and that's okay because that's usually the way they do it on the Saturday ones as well. Somebody says, and I don't look at the names, somebody has several questions. The first question is, about the last lecture, can both primary and secondary granules exist in cells at the same time? The answer to that is yes, because remember, some of the substances in the primary granules, like lysozyme, for example, are the same as the substances in the secondary granules. But the general rule is, once a cell gets into the promyelocyte stage and beyond, most of the so-called primary or aerophilic granules are gone, and you get into the more specific or secondary granules. Second question was, is there a single most important difference between lymphoma and leukemia in general? Well, I would say, to answer that one, there is no difference at all between lymphomas and lymphocytic leukemias. They're all part of the same spectrum. But there's a big difference between lymphomas and myeloid leukemias. Okay, third question. Can ALL, or acute lymphocytic leukemia, be diagnosed without staining for specific markers? Yes, the answer to that is yes, and it always had been before we had the markers. But now that we have the markers, there are certain lymphocytic markers which will identify those cells of being lymphoid origin rather than myeloid origin. And these will be strongly positive even if you can't recognize the difference under a microscope. Now, somebody said, why is there more interleukin 6 in multiple myeloma, and why is this bad for multiple myeloma? Well, that question I just don't know the answer to. Okay, I'll admit it. I know I got the first three right, but this last question, why is interleukin 6 a bad prognostic marker? I don't know the answer, but guess what? You could probably Google it and know in about 3 minutes. I should probably appoint some of you to be on the Google squad and answer questions like that. And I bet you, I still see there's 30 people here, and I wouldn't be surprised if 5 or 6 of those have Googled it already. And if you have, just don't be afraid to type in the answer, because I don't know. Okay, let's look at the questions now from the microphone and see if somebody wants to talk, because I've been talking too damn much. So let's look at the other list and see if there's any hands that are raised. And if not, we'll close it with a very beautiful song. No hands are raised. That means I explained everything thoroughly. And I know a lot of you just don't want to open your mouth. Of course, you can if you want. And I also know that a lot of you, maybe your English is not that great either. And I understand that as well. And I noticed that with a lot of our international students, they generally can ask a question much better if they are typing it into the question box rather than speaking in what we Americans would call a heavy accent. Okay, thanks. It was a great day. We'll probably finish up on the next session. It's exactly 11 o'clock, which is where we want to be. And you know, oh, it looks like I lost the last song, so let's get it out of the trash box. I hope it's still here. Ah, here it is. It's by Barbra Streisand and Bryan Adams. And I think you're going to love it. It's beautiful and inspirational. See you in 5 days exactly, minus 2 hours.
Someone to share my life. I finally found
Rock on, you buzzards.